not further reducing the risk. This doesn't mean that we should not control from 9 to 7. That should not be the take-home message. But pushing it down below 7 may not help patient for a further reduction in the cardiovascular risk. That was the message came from all these three quite famous trials in last few years. And also these trials showed us a very new insight about hypoglycemia. So one of the reasons why it failed was that when you try to achieve glucose control 10 years after the duration of diabetes has been set in, and for the 10 years patient is not under control, and then suddenly he becomes aware because he has complications to push it down, this may not be good. Suddenly at this stage, if you push it down too low, maybe below 7, this may not be good. And that fast reduction of A1C was dangerous. That came from the Accord trial. So it's not only the glucose control or A1C or the fasting good and the postprandial good, but what we are trying to achieve is a whole reduction in the glycemic burden as a whole. So 24 hours, 24/7, the glucose should be below whatever target we have realized. At the same time, it should move in a very narrow range. That is called as decreasing the glycemic variability. And there are a lot of new reports that if the variability is less, it is much better for the cardiovascular risk. And also there is a recent paper from the ICU study that in the intensive atmosphere also, if you reduce the variability, that is shooting up very high and getting a hypo is bad for the patient, it increases mortality. And we know that there is all these trials, whenever we try to achieve intensively, there is more hypoglycemia. That's what expected, and it was seen in all these major trials. One episode of hypoglycemia is very nicely documented in ICU settings, that these changes in QT interval, not only they come, but they are prolonged and they stay for more than 48 hours. And these have been published. And so it's not ECG changes are transient. Even though the hypoglycemia is corrected, the ECG changes remain for next 2 days, and there is an increased cardiovascular risk during those periods of hypoglycemia. Also, if a patient gets a severe hypoglycemic episode, we know that he will just stop the tablets. That will increase his glucose variability. At the same time, the adherence to the drug is less. So we have to avoid any symptomatic hypoglycemia in a patient when we are trying to achieve any glucose control. Up till now, we were looking at hypoglycemia as a low glucose, so our doses are more. So you treat it with the glucose and reduce the dose. That was the only understanding of hypoglycemia. And we want to treat it early so that it should not go to the irreversible brain damage. But after these 3 major trials, we know that severe hypoglycemia is a risk of vascular events and the death. So actually, it predicts death. So whenever you are trying to push down A1C, we know that hypoglycemia risk is increasing and also the weight gain is there. Also, there is something asymptomatic. The whole hypoglycemia definition actually changing. If you know, we call it as a relative hypoglycemia. Even that is important. A person who has got a, say, 300 glucose, and you put him on metformin, his glucose goes to 300 to 150, still he gets symptoms of hypoglycemia. Even that is called as a relative hypoglycemia. So hypo is not only going below 50 and patient needs sugar or some help. That definition, that may be a severe hypoglycemia, but even these hypoglycemias which are not documented, not realized, or relative hypoglycemia are very important because they increase the cardiovascular risk. So there are a lot of asymptomatic episodes of hypoglycemia which may go unreported. And if a person has got these kind of episodes, actually it increases the cycle of getting the next hypoglycemic attack, and which may be more severe. We have seen these phenomena in type 1 patients, and we know that they become hypoglycemia unaware. Same thing happens also in type 2 diabetes with the longer duration of diabetes. And treatment is actually to increase glucose and decrease the variability, keep them 150, 200. Within 1 or 2 months, the patients become aware of hypoglycemic symptoms. That's the way you treat hypo unawareness. And this is nice studies done in the healthy volunteers that if you induce 1 episode of hypoglycemia, there are a lot of changes in the next day morning about the quality of life or the cognitive functions. So it is important. Again, it's a major barrier for that aggressive control of glucose, which we are trying to achieve in all our patients. And we know that these trials have shown that what is the major predictive thing for the next attack in a non-CV patient who has a high risk? We know that low HDL, A1C, age, duration of diabetes, these are the major variables, but even an episode of hypoglycemia predicts a future attack or death in a high cardiovascular risk patient that came first from the VADT and not from the VADT and also from the advanced trial. The surprising thing from these trials came advanced and VADT measure, ACCORD was stopped because of the deaths. But these two large kind of a good clinical programs told us that it's not only when you are trying to reduce to 6.5, you are targeting 6. Also in patients when there is a 9A1C and you are pushing it down to 8% in a high cardiovascular risk, even if this patient gets a severe hypoglycemia, it is not good for that patient. So whether you are trying to achieve an intensive goal or whether you are trying to treat conventionally, a severe hypoglycemia is not good for a patient who is at a high cardiovascular risk. It predicts a future event as well as death. So whenever we are trying to use all these gadgets to target that glucose in our patients, we need to have drugs which we can avoid hypoglycemia. That's why actually when the gliptins came in the market, there was a lot of, even of course we are using lot of combinations of metformin, glitazones, long-acting insulins, so that to avoid a severe hypoglycemic attack. But of gliptins, when they came, GLP-1 based therapies, it actually addressed very differently to the basic pathophysiology of diabetes. And that was the GLP-1. We all know that GLP-1 is also quite instrumental in controlling the glucose because it stimulates insulin secretion from the beta cells whenever the food enters the gut. So this GLP-1, if you infuse, you can see that glucose goes down. I'm sorry. At the same time, the insulin increases because they stimulate the beta cells to secrete insulin. And the major effect of these drugs is that there is a decrease the glucagon, which remains is not responding in type 2 diabetic patients. It responds to the GLP-1 based therapies. And that effect on glucagon is a unique effect of all GLP-1 based therapies. And that's why when these drugs came in the market, GLP-1 analogs or DPP-4 inhibitors, they were completely different because whatever insulin comes from the beta cells is the glucose dependent. So if glucose goes below a certain level, whatever insulin coming, it stops because insulin comes only whatever is required. So the hypoglycemia risk is much less with GLP-1 based therapies, and also its unique effect on the glucagon helps to avoid hypoglycemia. That is the incretin effect. So how can we use this GLP-1? Either we can use continuous exogenous administration, or we can have a long-acting GLP-1 analog which is not resistance to the DPP-4 enzymes, which actually cleave this active GLP-1 to inactive within minutes once the GLP-1 comes in the circulation. So, or the DPP-4 inhibitors, which actually inhibit this enzyme, so that whatever GLP-1 active, it remains for a certain time in the circulation and controls the glucose. So coming back to these DPP-4 inhibitors, which improve GLP-1 levels a bit pharmacologically, not to the tune of the GLP-1 based therapies, or not in the 1,000 times high what we see in the patients of the gastric bypass surgery, but to a bit of pharmacological increase in the GLP-1 level. And this increased level actually improves the insulin, glucose, as well as the glucagon based their action. So all DPP-4 inhibitors, we are having almost 4 in the market, many new are in the pipeline and will be coming in few days or few months time. There are certain differences, we are not going in the details, but we know that if you look at the therapeutic effects of DPP-4 inhibitors, there is no difference between the glycemic control. So glucose control is almost same. There is a large research programs, we can say vildagliptin has a lot number of patients in clinical research programs, sitagliptin has, linagliptin has, and there are many number of patients who have come from these Asian countries. So we know that we can use these results to apply to our population also. So it also targets alpha cells and the beta cells and multiple levels of pathophysiology of type 2 diabetes. So definitely it is a much better drug. Improvement in the insulin secretion as well as the sensitivity, lesser risk of hypoglycemia. And we know that there are animal studies which very clearly show that there is a beta cell regeneration, and even in the all human clinical research program, we are saying that pro-insulin-insulin ratio and the beta cell sensitivity improves with GLP-1 based therapies. As I said, there's a large number of patients were from our country, so we know that all the results we can apply in the real world in the clinical practice. Response in Indian type 2 diabetics was slightly, I think everyone now we have used for many years, and we are aware that they are responding in a much better way in our patients, maybe more than expected. So whatever we are expecting to happen with the using these molecules, they are proving or acting much more than our expectations. At the same time, initially when these drugs came, it was the thinking that as the duration of diabetes increases, so a person with a longer duration of diabetes may not have that much of GLP-1. It also goes down like beta cell deterioration, and these drugs may not act. This thinking was challenged by the new articles that it is not like so, and even we are seeing in clinical practice a person of 20 years of diabetes, multiple insulin injections, we are putting that patient on DPP-4, he is responding very well. So many times we are stopping insulin. So that is also one thing. At the same time, let me just comment, when we are combining on a patient with the large doses of insulin or maybe strong sulfonylureas, as a third line agent, when we add DPP-4 inhibitor, you expect a hypoglycemia in first 48 hours. Even though we say this is because of the background treatment, if patient responds to this, the action of insulin and sulfonylurea, patient may get a hypoglycemia. So when you are adding this drug as a third drug or over insulin, you need to be a bit cautious, even though we say they do not produce hypoglycemia. There are large programs which say monotherapy it is effective as an add-on to metformin. All the clinical research program have shown it is almost same efficacy as sulfonylureas. That was also a very good understanding, and we are using it. Except the cost, I think they are same or better than sulfonylureas. No good data on comparative effectiveness of different DPP-4 inhibitors, so all are same for reducing the glucose. And durable reduction. So we have 2 years data, maybe 4 years data, that whatever effect they are showing in the initially, it is remaining there, and the data and the duration is increasing as the new molecules are entering the markets with the better clinical research programs. There are some differences in the mechanism of action because of their structure, but it is basically about pharmacokinetics, the duration of action, how it is excreted. So there are a lot of things you must be hearing about how these drugs bond. So like vildagliptin, it bonds differently. It has a more covalent bonding, so it is not a competitive inhibitor. So maybe with that twice a day dose, it is acting better. Or maybe linagliptin has a different structure and excretion is different, so it is better to be used and it is more longer acting. So these kind of differences are there between these different DPP-4 molecules. A single daily dose provides 24 effects. The vildagliptin needs to be given twice a day. There is a large plasma distribution which bind poorly to plasma proteins other than the linagliptin, which has a strong bonding. So saxagliptin has got these kind of effect on the cytochrome P450, and the excretion of linagliptin is slightly different, so maybe it can be used safely in renal patient, but you can use other gliptins also in renal patients by reducing the doses. So it depends on the patient's GFR when you are using these. As we all know that GFR has to be there in front of every patient where your type 2 diabetes you are trying to treat. Maybe for DPP-4, NSAIDs, antibiotics, about your antihypertensives, you need to have a GFR in front of you. There are certain non-glucose, just a small mention about non-glucose effects of DPP-4 inhibitors. We all know that there is some negative feedback. It reduces certain cardiovascular risk markers like MCP1, and it also has some beneficial effects at the cellular level, which has an improved kind of a cardiovascular outcome. And these effects may not be through GLP-1 receptors. So DPP-4 inhibitors may have a different effect than the GLP-1 based therapies. But all these kind of treatment are definitely showing a better cardiovascular outcome in their initial research program. And I think I will say all these molecules are having with the large cardiovascular risk prevention program going on. And I think the first escort will be published with sitagliptin. And already their clinical research programs are showing much less cardiovascular event. So this effect of DPP-4 inhibitors is definitely it's quite welcome for our patients, because we do not have any drug except metformin that it will reduce cardiovascular risk in our patients without producing hypoglycemia. Selectivity, just to mention, we know that this doesn't hold true in the clinical practice, and lots of data are there which say that it doesn't have any effect when you come about the selectivity, all are same. This was a very nice systematic review. These are the last few 2-3 slides. even though we say there is a clinical research program, so this article has reviewed all RCTs and they have compared DPP-4 inhibitors with other anti-diabetic drugs. And it is quite good to know what is happening when you are doing this systematic review and analyzing these results. So glycemic efficacy was seen as a monotherapy versus metformin. This results was again seen, and as a monotherapy, metformin is, what it showed was metformin is superior to DPP-4 inhibitors in reducing HbA1c. Only a minimal number of hypoglycemias were observed in any treatment arm in trials comparing a DPP-4 inhibitors with metformin as expected, and also with pioglitazone. No difference in the incidence of GI events, which we commonly see. When you are compared to the comparator, whether it's a placebo or other drugs, there are no increased GI disturbances with DPP-4. In fact, the GI disturbances were much more with metformin, and that we all see in our clinical practice. There are many patients, they have GI disturbances with large doses of metformin. Then there was nasopharyngitis, URTIs or UTIs are almost same as a comparator, whether it's a placebo or other anti-diabetic drugs. So in conclusion, as a monotherapy, metformin is superior to DPP-4 inhibitors, but associated with higher incidence of diarrhea, nausea, vomiting. And combined with metformin, DPP-4 inhibitors seem to have a similar glucose control effect, similar to sulfonylureas, but have a neutral effect on the body weight and have a low risk of hypoglycemia. So overall, if you're trying to meta-analyze with all the drugs, all the clinical research program together, again it is showing the results which are expected. This gives us a good kind of a confidence in using these molecules in our clinical practice when we read such articles. So thank you so much.
Thank you, Dr. Shailaja, for a very comprehensive lecture. I want to ask one question.
Yeah, please.
We say that sulfonylureas are secretagogues, and that's why in long-term use they cause beta cell exhaustion. In a way, these gliptins are also secretagogues. They stimulate insulin secretion. So in long-term use, will they cause beta cell exhaustion?
Even with sulfonylureas, we are not sure whether they really produce, because there are different kind of trials. In the short trials they are showing, but in the long-term trials, it may not be like that. The beta cell exhaustion is a intuitive phenomena of beta cells itself as an apoptosis, and it's a hallmark of type 2 diabetes. We don't know whether it is because of the drugs. But if you compare between sulfonylureas and DPP-4 inhibitors, it is definitely less with DPP-4. And that has been seen also in the human studies.
Any other question?
Practice now almost 32 years. I have seen patients with hypoglycemia, but I have not seen patient dying of hypoglycemia. But I have seen patients with hyperglycemia getting not only into cardiovascular risk, renal problems, eye problems, peripheral vascular disease. So which is more dangerous?
When we say avoid hypoglycemia, we are not saying keep patients in hyperglycemia. We are saying pushing below 7% may be risky. And even though whatever glucose control you want to achieve it without hypoglycemia. When we say these observations in the clinical practice, it's very difficult to comment on our observations because they are not systematic reviews. If you take out your 500 patients and 500 hypoglycemias in last 1 year in all your patients, you may find the results that hypoglycemia is bad. And usually, that was again a study of VADT and advance, that those patients who had severe hypoglycemia, they were actually ill patients. So again, hypoglycemia may not be the causative thing. It may be just an associated marker that it just says that patient is ill, patient has autonomic neuropathy, he has a long duration of diabetes, he has other problems, and that's why this person is dying. So whether it's causative or associative, we need to find it out.
I think hypoglycemia causes sudden cardiac death, while hyperglycemia will cause prolonged death, means prolonged complaints. So
Both
most
are
of the
bad.
hypoglycemia deaths are due to arrhythmias, and they are sudden cardiac deaths.
Yeah, but yes, that's what the program said, that these kind of hypoglycemias in a long duration of diabetes in high-risk cases may be bad because, as he has said, patients may be ill.
Madam, how much is the safety in renal patients, and how do you rate it versus repaglinide, gliptins?
Repaglinide is non-sulfonylurea secretagogue, and it is definitely because of its excretion we are using in the renal patients. About DPP-4 inhibitors, they are contraindicated if GFR is below 30. But if a moderate kind of a GFR, we are seeing linagliptin can be used in the same dose, and other gliptins you need to reduce dose, like vildagliptin you need to reduce dose to half, but we can use them in a compromised between 30 to 60 GFR. If patient is not having any GI intolerance.
Madam, you said there is reduced cardiovascular risk if we keep sugar level in a particular window. But if the patients are already diabetic for 10-15 years, these gliptins have come right now in the market since last 1 or 2 years. So if starting gliptins now, will they help to reverse some of the cardiovascular effects which they have already got in last 10 years or 15 years?
About the glycemic control and reduction of cardiovascular risk, we cannot comment like that. We have a UKPD's legacy effect, and ACCORD showed if you try to control suddenly, that sudden drop of A1C was bad. But if you see the advanced trial, a very gradual reduction of A1C, a large number of patients, even many number of patients from India in advanced trial, which has shown that even pushing it down to 6.5, it helps for nephropathy. So it definitely helps a patient to control glucose at whatever stage it is without having hypoglycemia. About the CV risk reduction with DPP-4, which may not be because of the glucose control, maybe non-glucose effects of DPP-4, it may be there, we don't know about it yet.
Madam, will you recommend DPP-4 as a drug of choice versus sulfonylureas for treating hyperglycemia?
Yeah, DPP-4 can be the first choice.
First choice,
if the
okay.
cost is same. But if the cost is a problem, then definitely we are still using sulfonylureas as a maximum number of patients.
Any more questions?
Madam, price of this DPP-4 is rather inhibition for the routine use.
Yes.
Does the Diabetic Association of India Research Group, Research Society of Group has given representation to the government regarding the price to reduce the price or something?
I don't know. I will keep this question for Dr. Panikar in his talk if he can answer that. He is advisor to major players in RSSDI. So, of course, these kind of recommendations are there, and now we are hearing a lot of MCI guidelines about the basic drugs to be kept, like statins came down or the aspirin. So one day it will happen.
Life-saving drugs.
Yes.
Thank you, Dr. Shailja.
I
And,
request Dr. Mrs. Chowji ma'am and Dr. Menon sir to felicitate Dr. Shailaja Kare ma'am. I request Dr. T.C. Rathod sir to felicitate Dr. Mrs. Chowji ma'am and Dr. Akhil Menon sir. The next lecture is on beta cell preservation in type 2 diabetes mellitus. For that, I would like to request Dr. P.K. Deshpande sir and Dr. Mahesh Shah sir to come on dais.
beta cell rate. स्लाइड चेंजर नहीं है अच्छा ते इथे माउस नहीं कर
Good afternoon, friends. It is always a pleasure to listen to Dr. Panikar all of you would glued to your seats. He is very crystal clear in his thoughts. And type 2 diabetes and beta cell preservation. No one wants insulin. Everybody wants to be on some or the other medication, preserve his beta cell as long as possible. Let us hear from Dr. Panikar about it.
Thank you very much, sir. Good afternoon, ladies and gentlemen. At the outset, I must thank the organizers for inviting me here, especially Dr. Rathod, Dr. Wagh, and their entire team. The topic given to me is preservation of beta cells, current and future strategies for effective beta cell preservation. India is the capital of diabetes. In fact, this is the latest, unfortunately I don't have a pointer. The latest figures are about 62 million diabetics in India, and you have 77 million diabetics, pre-diabetics. So the burden of diabetes is tremendous. And if you see, this is a study which we published almost 10 years ago, where we had studied 2 generations in the same family. If you look at the first generation, the age of onset was around 56 years. The second generation, 38 years. This is a 10-year-old study. But today we are seeing young people below 30 coming to us with diabetes. So the incidence is high, the onset is early. And nowadays people don't die very easily. Especially if you have money, Dr. Hiremat won't let them die also. You know, angioplasty, bypass surgery, renal transplant, and they go on living. 80 plus. So if you have a boy or a girl at the age of 25 who develops diabetes, they have got 50, 60 years of productive life ahead of them. And what is it that will keep them going for 50, 60 years? It's a good glycemic control, good control of their blood pressure, good lipid management, and that is what will take them further. And for a good diabetes control, you need to have a good beta cell preservation. Because ultimately, look at this, what is type 2 diabetes? It's basically insulin resistance and beta cell dysfunction. There are other factors, but primarily it's insulin resistance and beta cell dysfunction. This slide, if you look at the brown line on top, that is insulin resistance, which goes on throughout the life of the patient. The yellow line tells you the insulin levels. As long as the insulin levels are high, I wish I had a pointer. As long as the insulin levels are high, the patient doesn't become a diabetic. You have a lot of obese people who have insulin resistance, but beta cells are intact, they do not become diabetic. But as the insulin level, as the yellow line begins to come down, you see on the slide.
Roll your finger on this pad.
नहीं होता है, मैं बहुत रोल किया है. हाँ, आ रहा है. See that yellow line? No, it's changed to the next. एक mouse वगैरह कुछ है तो चूहा. Now the yellow line, when it comes down, that is the beta cell is beginning to fail, and that's when the insulin level drops. And that is precisely the time when the blood glucose rises and the patient comes to you. And when the patient comes to you, this is a study from the UK PDS. 6 years follow-up of newly diagnosed diabetics only on diet. There is a steady decline of the beta cell over 6 years. They are not on any medications. They are only on diet. So there is a steady decline, apoptosis of the beta cells. But at the time of diagnosis, according to UK PDS, 50% of the beta cells are already gone. But subsequently, Di Franzo has shown that if you look at this slide, say when impaired glucose tolerance begins, much before, that's a pre-diabetic stage, that is when 50% of the beta cells are gone, and by the time the patient comes to us, almost 80% of the beta cells are gone. So what you have left is hardly 20 to 30% of beta cells, and you need to preserve them maximum, because once beta cells are gone, obviously they will need insulin, and without beta cell, without endogenous insulin, the diabetic control becomes very brittle. In the initial stage, we all know we can easily control these patients. So why does this beta cell fail? What are the factors that contribute to beta cell apoptosis? If you look at this slide, hyperglycemia. any glucotoxicity is toxic to the beta cell. Hyperglycemia is toxic to the beta cell. Insulin resistance, which is an integral part of type 2 diabetes, is toxic to the beta cell. There is lipotoxicity because you have elevated free fatty acids, triglyceride, and these are toxic to the beta cells. You have an insulin processing dysfunction, about which I will talk, protein glycation, decline in progenitor cells. What are these progenitor cells? They are stem cells in the ducts